There are very many emergencies that occur day to day, from accidents to people with underlying conditions. And many Ugandans do not know about the emergency medical system. According to the Biomed Central Health Facility research, a study conducted on the state of emergency care and acute health facility in Uganda, findings in 2020 indicate that 16 out of 52 pre-hospital providers assessed have equipped ambulances, have the right medical personnel and medicines. However, the rest have the right ambulances, improved ambulances, but are not equipped well enough to provide pre-hospital care. Today we look at emergency medical services at Limia. You are welcome to the Health Code. A good evening to you. I'm your host, Hope Nyongereza. You are welcome, sir. Welcome to the show. Good evening, doctor.
Good evening, how are you?
Fine, thank you. So kindly introduce yourself first of all.
My name is Julius Nduguyangu Mujisha. Yes.
And
I'm a paramedic and I am a manager here at Life Medical and Rescue International.
also known as?
Also known as Limia. So very many people know us as Limia.
Okay.
Yeah, but Limia is Life Medical and Rescue International.
Okay, so what does Limia do in terms of emergency care?
Limia is a specialist in emergency medical services, emergency medical services and remote medicine. So what we do is we provide pre-hospital care service, hospital at home, remote medicine, which is where you find there's a company that has people in a very far area and they require medical services on site. So we provide you a standby ambulance, we provide you paramedics on ground, so we set mobile hospitals there, and we provide you a hospital, military grade 3 hospitals to the standard in emergency medicine. We also do HART, the only existing HART in the country. So HART is Hazardous Area Rescue Team. So if you look at the basics of emergency medicine, if let's say we have a disaster, a spill, chemical spill, not everyone that goes there is qualified to do it. So there has to be a specific team that is trained and equipped to deal with hazardous area response. So how do you pull out those patients? How do you treat patients that are contaminated, decontaminate them, and later take them into the system? It's not about going in because that means you'll be a problem.
We have heard of emergency care, but many people do not know what emergency care is and what it entails. So can you just give us an idea of what emergency care is and what it entails?
So emergency care is a complex process, but I'm just going to break it to the pre-hospital care. So when we talk about emergency care, we also involve security, we also involve the normal other emergencies. But let's look at the pre-hospital care. So pre-hospital care is the care given to a patient out and with the hospital. By that I mean you carry the hospital to the patient. So it has stages, we call it the chain of survival. Early recognition, intervention, equipment to stabilize the patient, and equipped ambulance to transport the patient, and the hospital that is receiving the patient also has to be equipped to receive the hospital. And that has to be a chain. So you have early recognition, you have a dispatch system, so you have to call a dispatcher sends an ambulance, the ambulance has to be equipped, the people who are reaching on ground have to stabilize the patient has to be taken to an ER, the ER has to be equipped and informed of the patient coming, and it is a smooth circle. So you will find that chain of survival, if one is broken, then you're killing the patient. If it continues, then you're giving the patient a high chance of survival.
So Mr. Julius, in 2020 we got to see that this is when the emergency care was actually known so much because of COVID. How did you come out in terms of COVID response?
That was I think it was an eye-opener to the society, but it was also the testing time for our capabilities.
Yes.
So during COVID, we had life-threatening. So emergencies has levels. So we have the basic, any emergency. We have life-changing and life-threatening.
So, doctor, you say life-changing and life-threatening. Can you give us more details about the life-changing and the life-threatening? Life-threatening
are injuries or illnesses that can change your life. For example, if you have a stroke, you may not die, but you'll not be able to walk. So that's life-changing. Yes. So if you have a traumatic injury and you have a broken leg and you have to be amputated if no one responds on time, that's life-changing. Okay. But then we have illnesses like catastrophic hemorrhage. You're going to bleed to death. That's life-threatening. Okay. Then you have heart attack, anginas, or cardiac arrests.
Yes.
Those are life-threatening illnesses. Okay. So those will kill you in 5 to 7 minutes. Yes. So that's why if you look at our system, for life-threatening and life-changing injuries, we have 45 seconds to leave station. Okay. So if someone calls in and someone has a catastrophic hemorrhage, then we have 45 seconds to leave station. That means we have to carry blood and blood products, and we have to have the levels of care have to increase. So either doctor has to be on board, an intensivist has to be on board if we have to intubate somebody in the field. So you need people who will. So our system is we take the hospital to the patient. We don't rush the patient to the hospital. Yes.
So Mr. Julius, you say in 45 seconds you have to be ready. Yeah. Is this equipment always ready? Like you say, the people are there, the personnel is there. How about the equipment, the ambulances themselves? Are they fully equipped for this?
So we have 4 levels of ambulance. We have the basic life support, which is the ones mostly you see around here in Kampala. Yes. We have the intermediate life support, we have the advanced life support, and then we have the mobile intensive care units. Okay. So the mobile intensive care units is a complete ICU but on the wheels. Oh, okay. The advanced life support are the ones that are extremely advanced. They will do everything that you will find in an emergency room, but out with the hospital. So we can intubate somebody in their compound. We can we can do emergency surgeries on the road. Oh, okay. Yeah. For example, we can do a resuscitative thoracotomy on the road. That is specialized by emergency medicine specialists.
How safe is that though, especially when the ambulance, it's moving? How safe is it?
It's not safe in the Ugandan sense, but everyone that is an ambulance, the ones we call EMTs, emergency medical technicians, that drive the ambulances, have an EVOC certificate. Emergency vehicle operating certificate. Okay. So they know how to drive, they know when to speed, how to speed, where to pass, it's to maneuver into that. Also, it has to be safe for the patient and safe for the driver and the team, because you don't want to rush so much and you don't reach. It's not about rushing too much, but you also have to strike the balance, especially with our border infested roads.
Yes, that's true. Yeah. So you're still explaining to us the different kinds of ambulances. Yes.
So basic life support is the type of ambulance where somebody has, stomach pain is okay, or is immobile, you need to take them to the hospital. Yes. Or you need to take them from hospital A to hospital B, which we call inter-facility transfer. Then advanced life support, we usually send that for people who are in a life-threatening conditions. Okay. So that goes with the doctor on board, critical care paramedic, intensive care paramedic, people who will do what the patient requires. So you will find that is a complete hospital, but on wheels. The mobile intensive care unit, those are specialist ambulances that will carry a patient that is already intubated. They have ventilators, you have everything you will find in an ICU room, but it's in an ambulance. Yes. Then that takes the patient from point A to point B. Okay. I think they are around, if I'm not mistaken, they are not more than 10 in the country.
those are very few.
Yeah, and we have around 60% of that. So, yeah.
Yeah, that's quite a small number, especially considering the emergencies that happen every day. So, Mr. Julius, you've given us the different kinds of ambulances and the kind of conditions they take. How do you get to find out that, okay, now this person is probably having a stroke, this one is from drowning, and how do you get to find out the kind of ambulance to send to these people?
So we use, our dispatch center is the international standard. We accredited and certified by International Academy of Emergency Dispatch. Okay. So when you call our dispatch center, it's as if you're calling the US or the UK. We use the same standard, and we are certified and accredited by the same standards.
Yes.
So when you call in, we have the system we use that will ask you a couple of questions, and the system will determine the ambulance to send and how it goes. So okay. It will determine this according to the information you give us. The patient that the ambulance that needs to go is advanced life support. It has to have a doctor on board. It has to, yes, and it has to go hot. By hot, I mean blue lights and sirens. So yes, sometimes we have patients and no blue. No blue lights and sirens, but we have a patient in the
So meaning the condition is not so serious.
Yes,
at that point.
Someone has a broken leg and they're just going home.
Okay. So you said the system determines.
Yes.
By system, do you mean the people, or do you have a computerized system?
It's a computer system that will determine. So when you use the people, they will influence your decision.
Okay.
So they will influence your decisions, and they will not be very effective in determining. So we don't want to influence that. So it has to be standard. Yeah. So whether, you see, let's look at catastrophic hemorrhage, for example. If somebody is bleeding to death in Kalewe or is a minister somewhere, they all need blood. So someone has to stop the bleeding. It doesn't matter whether he is a minister so-and-so or executive director of the other place or the market vendor in Kalewe. They all need life. So our response is standard.
Okay.
So we'll respond according to what the system tells us. But if it is a human being, then and say Minister 1, so I'm just giving you an overview of how the dispatch works. So 4 calls have come in, and you have 4 assets.
Okay.
So you have 4 calls, 4 assets. One is a minister, another one is permanent secretary, yes. Another one is an ED, and another one is a Matoke sailor in Kalero.
Yes.
Now, because the minister has called, you want to rush to the minister who has stomach pain.
Yes.
Yeah? Maybe something you've triaged and you've seen that that's not life-threatening.
Yes.
But then a Matoke sailor in Karewe is in a life-threatening condition. Would you respond first? If you're using a human being, he's going to respond to the minister first.
Yes.
If you're using a system, it's going to tell you, because the system doesn't look at names, it looks at the condition.
Okay.
So it will send the best.
Okay.
The best. So you send the most appropriate according to the injury.
Okay.
You understand my point? So
yes,
for us, we don't do political medicine.
Okay. How many emergencies do you receive in a day? As linear?
I can give you an overview probably in a month. One day we can receive up to 30.
Wow.
And one day we can spend the whole day taking chai. So so I can give you an average in a month. In a month we can handle up to around maybe 200 emergencies.
Okay.
Yeah. Between 150 to 100. So that's according to our system. Yeah.
Okay, so out of the 30 emergencies, what is that, what is most, is it the accidents?
Common?
Yeah, the most
we
common.
We have RTAs as the most common. The most
what
common
are the
RTAs as road traffic accidents.
Okay.
So RTAs are the most common. Lifestyle diseases are the second. And the third is interfacility transfer. So usually interfacility transfers, we classify them as interfacility transfers, regardless of whether it has been an RTA or not, or lifestyle disease. And so if they take you to a clinic and then the clinic calls us to take you to a bigger hospital, we classify that as an interfacility transfer. We don't classify that as an emergency response to your home, for example. Okay. So those are two different things. Because when we respond to your home, we start from zero.
Yes.
When we take you from a clinic, then we've started from what the clinic has done.
Okay.
Even though usually
are there cases where a patient has been in a clinic and an emergency has come up and they need to be rushed to a different hospital?
And that's how our healthcare system here has its flaws. I'll call them flaws, need to change. So we tend not to assess the patient based on need.
Okay.
So you have a patient who has a cardiac arrest.
Yes.
Or is getting a heart attack. You're taken to a clinic. The clinic has a nurse who can't even handle, who doesn't even have advanced life support training.
Yes.
So they tend to put you there and they take their vitals and take all that unnecessary interventions. And then they call you when they feel it's almost too late, because every facility doesn't want to record death. So, and what that happens is you are called, and when we ask questions, they feel very uncomfortable, because the questions that we ask tend to be, tell us exactly what happened. So if you're calling from a facility, we're going to ask you, does the patient require A, B, C? And it's like, hey, come and take the patient now. But if, the patient is okay, patient is stable. If a patient is stable, then why are you referring?
Yeah.
So we ask questions not to annoy people, but we ask questions so that we go equipped. It doesn't make sense for me to rush to point A and then reach there and I find I need a ventilator.
Yes.
But I've taken a basic life support. Or you tell me the patient is okay, because what you tell me based on the information I've gotten is what I'm going to do.
Okay.
So I'm going to deploy my assets best on the information you've given me. So if you tell me the patient is all right, it needs just basic transport, I'll send you basic life support. Then reaching there, and we have to escalate.
Okay.
So by escalating means then I have to send an intensivist, then we have to have a ventilator, then we have to have, so you're from basic life support to a mobile intensive care unit.